to discuss on the continuation of GI symptoms. Alice Stella ma'am is with us. You are all familiar with her. She had taken the last class on GI symptoms 1. Welcome, ma'am, and welcome all of you to our class. Ma'am, over to you.
Thank you, dear, so much. I hope all have joined. I can start the session.
They are joining, ma'am. You can start now.
Just a second. So, good afternoon to all, and welcome to my session. This is my second session with you all. I'll just share the screen. Is it visible?
Yes, ma'am. Not in presentation mode, but it is visible.
Put it in presentation mode.
Ma'am, it is still not in presentation mode, but I believe it is. It would be visible for us. If you can just increase the zoom, maybe that might help a little.
Now it is okay?
Perfect, ma'am. Perfect. We are good to go.
So we will be just talking about malignant bowel obstruction today. To start with, last day for yesterday, we have seen about nausea, vomiting, constipation, and spurious diarrhea. Okay. So in palliative care, this is one another thing which we come across, that is a malignant bowel obstruction. So, okay. So the causes of bowel obstruction in a patient with cancer. So usually it is two types: the disease associated and treatment associated. Disease associated intraluminal tumors, intramural tumors, extramural obstructions, infiltrating tumors, and of course the paraneoplastic when there is intestinal pseudo obstruction due to the obstruction of the enteric neurons. But when we talk about the treatment associated, maybe due to adhesions after surgery, radiation, intraperitoneal chemotherapy, that's the given for the dysplasmic reactions. Some of the drugs, anticholinergic drugs, do cause obstruction. Then severe constipation. In severe constipation, like what we say is when the stool becomes very hard and it becomes an obstruction, it can happen. And of course, some acute colonic dilatation and pseudo obstruction of the unknown etiology. So, a lot of causes are there.
You can continue.
So again, when you see, you can see in the ascending colon about 22%, 11% it is in the transverse colon, and in the descending colon 6%, sigmoid colon 33%, and when you see to the down portion, that is from the sigmoid colon to the rectum and anus, it is 27%. So ovarian cancers almost contributes about 5 to 51% of ovarian cancers can cause obstructions. Primary intestinal malignant diseases 10 to 28%. Breast, lung, and malignant melanoma are the common extra-abdominal malignancy causing malignant or bowel obstructions. And 15% of the patients in palliative care unit who come also do have malignant this one intestinal obstruction. So the clinical presentation rule of thumb, we said, higher the obstruction, more severe are the symptoms and few the signs. Okay. If the obstruction is on the higher side, there will be severe symptoms, but the signs will be less. But if the obstruction is to the lower part of the intestine, usually the symptoms are less severe, but more of signs will be there. So just we have a look onto this. See, symptoms and signs: proximal obstruction, distal obstruction. Okay, pain, colicky pain continuous pain also. Here, in the proximal obstruction, early symptoms like periumbilical short intermittent cramps will be there. But in a distal obstruction, what happens? Late symptoms localized to the site, deep visceral, long intervals between the cramps. Okay. Now vomiting, it's a sign. The proximal obstruction, usually large amount of vomiting will be there. It can be watery and bilious, no or little foul odor. But when you talk about distal obstruction, the vomiting will be of small amount, and of course there may be present foul odor present. Distension of the abdomen. In the proximal obstruction, usually distension of abdomen is absent. Constipation may be present. But in the distal obstruction, distension of abdomen will be present, and of course there will be a paradoxical diarrhea present for up to 1 to 2 weeks. And what is paradoxical diarrhea? Nothing, that is a fecal impaction. We call it as a paradoxical diarrhea. When the colon is being struck by a fecal matter. So that is called a paradoxical diarrhea. Okay. Now let us see the sign and symptoms. Depends on the site of the obstruction. In gastric outlet obstruction, early and severe nausea and vomiting will be there. If it is in the gastric, if it is gastric outlet obstruction, early and severe nausea and vomiting will be there. In small bowel obstruction, more of cramps will be there with nausea and vomiting. But in the last bowel obstruction, the symptoms appear very later. Considerable distension will be there, and of course there will be a paradoxical diarrhea due to the bacterial overgrowth. So these are the three different things that can happen in the gastric outlet obstruction. It could be early and severe, small obstruction, more of cramps will be there with nausea and vomiting. But in the last bowl, usually it is the symptoms appears very late. Okay, with the considerable distension will be there, and they will have a diarrhea. Pain can be of two types. Some people, they complain of continuous pain, but in some cases they do complain of cramps. Every now and then they are having pain, mostly after the meals. In nausea and vomiting, again, if it's a large bowel obstruction, there could be this feculent this one vomiting will be there. Whatever particles are there, it will come out. Okay, and feculent most probably it could be fecus also. But in a small bowel obstruction, the biliary will be the this one. What is it? The content which comes out in the vomiting, and biliary is usually in the small bowel and the gastric outlet obstruction. So these are the two different things that can happen. Constipation, of course, flatus and stool are absent in complete obstruction. If there is a complete obstruction, if you ask the patient will say, yeah, no, I am not passing even flatus. Okay, and altered bowel sounds. So usually how do they investigate? One thing, that's the clinical features what I have spoke to you. Like patient will give you a history of the abdominal distension, otherwise nausea, vomiting, cramps, colicky pain, and all. This is one side of the system. Clinical presentation they may give. Even they can give you constipation also, the history. Okay. And another is the history of the disease or the treatment related. Okay. Now, plain X-ray abdomen can be taken. Another one is about CT abdomen. Nowadays, most of the time it is CT abdomen. Okay. In the plain X-ray abdomen, usually what they say is like, usually the proximal obstruction will be normal. Distal obstruction, there will be dilated bowel loops, and useful in ruling out constipation causing pseudo obstruction. When there is a pseudo obstruction due to constipation, it is useful. Okay. CT abdomen can be. CT scans are very useful. Most useful test, about 100% the test will be positive and reliable also. Okay. So CT also can be done because it locates the obstruction, where the obstruction is, and helps us in taking the decision making what we could go to, whether we further management. Accordingly, we can take the decisions, and it defines the area around the obstruction. Wherever the obstruction has happened, we'll come to know why this has happened, what is the cause of that obstruction. So let us see the management. So rarely an emergency. Rarely in emergency, but emergency also can happen. Evaluate their overall status, including the stage of their disease trajectory and goals of the care. So this we have to keep in mind. If the disease trajectory is going down and down, our goals of care also will be different accordingly to the patient's condition. Okay, so whatever we are going to do the management, we should focus on these two things. But we have to address to the pain, nausea, vomiting, and of course the fluid status of the patient. That is very important. Whether the patient is in the end of stage or whether the patient is still going with them. Pain should be always addressed. So you all know this many days you have been taking, you are attending so many classes. What we say is quality of life. So quality of life is very, very important. So here, even if the patient is in the end stage also, pain has to be addressed. These symptoms has to be addressed. That is very, very important. And of course, if needed, we can do some blood investigation to know about the electrolyte imbalance. Okay, if there is some problem. So the management, frequent mouth care is very important because after vomiting, you know, the mouth will be having some foul smell. Okay. I remember one patient with the intestinal obstruction who had come to us. This is a cancer patient in palliative care. The patient was having a mug with him and he was vomiting, and whatever he was vomiting, it was fecal matter. And his wife and children, they were around and they were thinking, what is this yellow coming? Actually, we could smell the fecal matter. Okay. This patient was knowing that he is vomiting fecal matter. So we need to give them the frequent mouth care is very important. We can offer even ice to suck small amounts of food and fluids. If there is no complete obstruction, I'm talking before. If the patient is dehydrated and not dying, IV hydration is very, very important. Okay. But in a long term conditions, of course, we can go for subcutaneous fluids, but choose the route of administration. Choose the correct route of administration. Remember the patient's quality of life. Treatment, conservative treatment, allowing gastric decompression. Usually you all know about it. Whenever a patient is having continuous vomiting, we put an NG tube and continuous drainage we put so that the patient is not vomiting. Okay, so that is very important. An NG tube has to be placed. Whatever content is there, we can just aspirate and do a continuous drainage. Acid suppression has to be done. So proton pump inhibitors can be used. I'm not going to very detailed with the medications, okay? Because usually what the doctors prescribe, we go for that type of medications. But just for your knowledge sake, I'm talking. Avoiding prokinetics, avoid metoclopramide and domperidone. Okay, so in intestinal obstruction, we have to avoid metoclopramide. Now, usually it is called as Reglan. And as analysis, we can use whatever is available in your hand. Please see that the analysis is given to reduce the pain of the patient. Antiemetics can be given like haloperidol. You can see cyclizine is there, olanoprostene is there. A lot of drugs are there. Any anti-secretory we can give, like buscopan, and this one, octreotide, we can give glycopyrrolate, especially glycopyrrolate helps in colicky pain. So to reduce the secretion, we can give these things. Next is anti-edema. Dexamethasone. You remember I told in the last class, dexamethasone is a very good drug to reduce the peritumoral edema. Okay. Of course, they use methyl prednisolone also. So whatever is available, we can use. Avoiding overhydration. Minimizing hydration to avoid gut wall edema. So here, overhydration has to be minimized. Otherwise, they will have the gut wall edema will be there. And of course, antibiotics. If the patient is, we suspect the patient is having any GI sepsis secondary to bowel obstruction. So these are some conservative treatment that can be done. So this is why about the octreotide. Usually this is used because it decreases the gut secretions, increases the absorption of electrolytes and water, relaxes the smooth muscles of the gut. Okay, so it has a lot of what to say, usefulness is that you can see decreases luminal content, decreases luminal motility, decreases luminal congestion, decreases ascites. So many patients do use these medications. That is buscopan. Again, buscopan decreases the gut kinetics, decreases the gut secretions, and relaxes the gut smooth muscles. That relaxation, it itself will help the patient, that pain will come down. So these are some things. Anti-inflammatory, dexamethasone, very usual. Anti-inflammatory we can use. Then we are talking about this one, dexamethasone. Dexamethasone usually in palliative care we give in higher doses. Okay. Now, what bedside management of a patient with malignant bowel obstruction we can do? What are the bedside management we can do for such patients? First and foremost is accepting the patient as the patient is. That is very important. Second, control the pain and other physical symptoms. So reassuring the patient is very important at the bedside, because the patient will be having pain, he may be nausea, vomiting, and as I said, maybe vomiting the fecal matter, whatever it is. So be at the bedside of the patient. As a nurse, this is very important. Reassure the patient. Allow patients, one of the family member, to be with the patient. That is also an important. Maintain optimal hydration and nutrition. If the patient has an NG tube, make sure the tube is petted and the output is recorded, and just keep it open so that instead of the patient vomiting, everything comes out of the NG tube. Electrolyte balance and should be managed. Sepsis should be managed. Abdominal girth and auscultation of the abdomen is very important. So at least in every shift, otherwise 4th hourly, we can take the girth of the abdomen. So usually this happens, usually it is being done 4th hourly, otherwise every shift. Okay. And of course, accurate prognostication to determine appropriate course of treatment. So now the thing is, when we do the goals of care, we have to prognosticate to see what appropriate treatment we can give to this patient. Whether our treatment, second, prognostication is very important. Then only we can decide what to do further, what management we will do for the patient. So the appropriate course of treatment remains on these things. Interventional or invasive we can do is useful in proximal. There is a proximal malignant bowel obstruction. As a temporary measure, we can put a NG tube. If there is no NG tube, we can put a NG tube. Okay. Vent gastrointestinal secretions. How is it? It decreases the abdominal distension and decreases the vomiting. because all the gastric fluids comes out, stomach contents comes out. Okay. So what is the abdominal distension also decreases and the vomiting also decreases. The issues are, one is discomfort, pain. You all know when we pass a NG tube, most of the time, what I have also come across patients saying, please, can you remove this? I feel very discomfort with this. And of course, some problems do arise like aspiration, pharyngitis, esophagus, erosion of the nasal cartilage or esophagus, and of course, social isolation. Many of the patients do not like this tube put over here, and that is being viewed by the public. So they isolate themselves. Social isolation is the okay. So NG tube is good. If the patient is already in NG tube, well and good. But if not, then we have to go for an NG tube so that it will reduce the patient's abdominal distension and reduces the vomiting. Now, when is a venting gastrostomy done? What we call as a peg and all. Okay. Usually it is indicated in the patients unresponsive to medical management. If this medical management is being done and the patient is not responding, then we can go for a gastrostomy. With multiple levels of obstruction, poor performance scales, not a candidate for surgery, and life expectancy is less than 1 month. In such patients, we can go for a venting gastrostomy. This will relieve about 80 to 90% cases, there will be a relief. And as you all know, this is done with a surgical exploration. But it is contraindicated in patients with tumor encasing the stomach, diffuse carcinomatosis, massive ascites, previous abdominal surgery, tumor attached to the anterior abdominal wall. If this is the case, a vent is being, venting gastrostomy is contraindicated. Anyhow, this all the surgeons have to take a decision upon that. So when surgery has to be done, I'm not going to detail, just like this, when there is an advanced malignancy, as I said, with poor performance, in the sense patient is slowly moving to the end stage. Okay. And when it is spread all over the abdominal cavity, there are multiple types of obstructions are there, recurrent obstructions are happening. In these cases, any surgery won't be done. I'll just remember, not only intestinal obstruction, when the patients with colostomy come with the obstruction, many times when we send the patient is sent back saying that nothing can be done. Okay. Most of the time, why it is not been done? Because one will be a poor performance status. The malignancy must have again advanced. There could have been multiple sites of obstruction. So the surgeon will take a decision not to be done. It's only beneficial. Surgery is only beneficial when there is a single site obstruction. The expected survival is more than 6 months. And of course, good performance and nutrition states are okay. So these are the some things where the doctor takes a decision when to do, whether to do it or not. Now, total parenteral nutrition is justified in patients with minimal tumor burden and the candidates who are definite for surgery and in patients with good performance scale. Say the patient can be operated, patient is also doing well. In that cases, they can have a total parenteral nutrition. And also used in intermediate to good life expectancy who may otherwise die of starvation than that of a cancer. So suppose the patient's life expectancy is okay, but cannot go for a surgery also. In that cases also, instead of the patient dying of starvation, better to give a this one, total parenteral nutrition. So this also can happen. So why we give metoclopramide to stimulate the gut? Usually we give metoclopramide, what we call as Reglan, but we have to be very careful, beware of any increase in the gut colic. If gut colic is increased, we have to stop. And if we stop, if obstruction is not resolving. And especially in complete obstruction and all, we cannot give Reglan. Okay. For complete obstruction or obstruction not resolving with above measures, in 1 to 2 days, focus on treating symptoms than the underlying cause. That is, if there is a complete obstruction or the obstruction not resolving within 1 or 2 days, we have to treat the symptoms of the underlying cause. Constipation, if constipation is there, you can just do a gentle rectal measures of giving a little bit of softener. And if there is no colicky and obstruction, is thought of being colonic and subductive obstruction. So thank you. 1 second. What happened in the center? I don't know. Okay. One more, before stopping, I would like to share something also. We have to be very careful when a patient comes to us, especially in palliative care, when a patient is complaining of severe nausea and vomiting, abdominal cramps, and giving a history of there is a distension, slowly the distensions increase, there is a constipation. Okay, immediately we have to inform the doctor. That is one thing. Second thing, as I said, reassure the patient, be with the patient. Okay, family should be allowed to be with the patient. As I said, when they start vomiting fecal matter and our patients get distressed seeing they are vomiting fecal matter, which has to come from the anal this one route. It is coming from the mouth. Okay, so that is very, very important that a nurse should be there with the patient, next to the patient, to reassure the patient and not to leave the patient. And I still remember one case. I will tell you. One case means because not one case, I mean one person. I was very young that time, but I can recollect the things now. Especially my mom. She has undergone a surgery in 1971 for a renal surgery. She undergone, and after that, somewhere in 78, 71, she had undergone the renal surgery. But in 78, what happened was, suddenly one day, we could see her crying out with pain, severe abdominal pain. She was crying, she was vomiting, and we were small children. I was hardly that time 8 years old. Okay, we all gathered around her mom, and we were asking what happened, mom. We were not knowing what was happening with her. She was crying severely. By the time my dad came, and he just took her to the hospital. Okay, and after the next day only we came to know our mom has undergone an emergency surgery. Okay, and at that time we asked our dad what happened. So he said there was an obstruction. In the sense, he said there was an obstruction, so mom was operated. But after joining my nursing only, actually I came to know actually what happened to my mom, because it was due to the adhesions. Adhesions were the previous surgery adhesions. There was an obstruction, and they had to relieve that. Okay, and I had a subacute obstruction also. I tell you, it is very, very bad, because I have undergone 2 abdominal surgeries, major surgeries, and after about 4 years, due to the adhesions, I had a this one. It was a subacute obstruction. They gave me only conservative treatment, but I tell you, the pain was very bad. I couldn't do anything, and I was not knowing why I'm getting the pain also. Little bit of abdominal distension was there. Actually, I was not passing the flatus and all, but thanks to the my doctors who really actually I didn't go for a surgery and all, but they helped me out. And today also, when I think about these things, okay, sometimes I feel, my God, what will happen ahead? Because our age is advancing, something happens. So remember, when a patient is having, especially when the abdomen is distended, our posture also changes. Okay, with that, your just vomiting, and already you know you are having a cancer. In this condition, the patients become very distressed, and the family also. And the family also don't know what to do. And that's how they rush to the palliative care. And at times we have to send the patients immediately to the this one other departments to find out whether something can be done. Okay, so with this I stop my this one presentation. So any queries we can go ahead, otherwise we'll go with the presentation.
Thank you, ma'am, for the presentation.
Ali Hamod Salala Hajri. Very sorry, I am not a doctor. Okay, I am a nurse. I am a retired from already retired person.
Thank you, ma'am. And if you have any doubts, please put it on the chat box or unmute yourself and talk. Either raise your hands, please. Any doubts?
Yeah, I just want to ask you all are from different countries. I would just like to know whether do you come across this kind of cases in your setup? So Kalaivani is asking, ma'am, why vagotomy was not suggested for patient with severe pain? Kalaivani, I am not so sure about this, why it is not suggested for with severe pain. I don't know why. Usually we treat the pain, that is one thing, one side. And accordingly, the patient with the patient's condition, we go ahead with the further management. As I said, when the patient is coming to the palliative care, and if it is advanced and the patient is having what to say, patient is in end of stage, we always focus on to the end of life care things. Okay, so like pain management we do, correct. And if we feel the patient needs a little bit of hydration, we give the hydration. That is all. This what you have asked about the vagotomy, I also don't know, dear. Have you come across something like this? Kalaivani, you can unmute. Yeah.
Yes, ma'am. When I'm working there in Apollo for a short period, I have come across the person who undergo for a vagotomy surgery because of the severe pain.
It's in a corporate hospital?
Yes, ma'am.
Corporate hospital. So I have been working in a, what to say, government hospitals, but I have not, so I don't know much about that this one. Because see, when we compare the government and the this one corporate hospitals have a lot of things to do nowadays. Okay, and you know about the government setup, not have much this one unless some, of course, very this one what to say, talented doctors come over here who have been done in the corporate hospitals. They try to do many things, but about the vagotomy, of course, I have not come across that.
Thank you, ma'am.
Welcome.
Thank you, Kalaivani. Any other questions from anyone else?
Is there a presentation?
Yes, ma'am. Today we are having a case presentation by Nimila lecture. Shall we move to the case presentation?
Yeah, we'll just move to that so we can have some.
Nimila?
Yes, ma'am.
Nimila, I will be sharing the screen for you. Just please start the presentation. Okay?
Yes, ma'am.
Nimila, you can start now.
Ma'am, I have sent another presentation.
Excuse me?
I have sent another presentation.
When did you send that?
Uh,
Oh, yeah.
it is 32 years male. He is a police officer. He is married but did not have child. Coming to diagnosis, known case of cancer lung with distant metastatic with seizure disorder, acute kidney injury, anemia, and scrub typhus positive. On admission, patient had the complaint of fever, headache, loss of appetite, nausea, vomiting, seizure for 2 episodes, loose stool for 2 to 3 episodes. Came to medicine ward on 5th of March. Coming to the history of illness, patient is known case of lung cancer stage 4 on December 2019 from Delhi AIMS. Chemotherapy was not advised as it's already in stage 4. Instead, the doctor was advised tablet siritinib 150 mg into BD. Patient and his family member are well known about his condition and diagnosis. Also having history of COVID positive on January 2022.
Please change the slide.
Coming to physical examination, on admission, patient BP was 60/40, pulse rate 84, temperature was 100.1, respiration was 24, SpO2 was 91 in room air. RBS was 141 mg per dl, weight 48 kg, pallor was present, and no cyanosis. Central nervous system normal, central vascular system was normal, respiratory is bilateral air entry present, normal vascular breath sound heard, abdomen was mild epigastric tenderness, ascites, there is no ascites, muscle whistling is present, upper limb and lower limb are normal, genitourinary is no abnormalities.
Stella ma'am, have you asked anything before?
No, nothing.
Okay, ma'am.
Significant investigation. On admission, RBS was 145 mg per dl, KFT, urea was 65, create was 2.8. Sample was repeat on 8th of March. Urea was 56 mg per dl, create was 2.0 mg per dl. LFT within normal range, serum electrolyte, sodium 145, potassium was 4.5, chloride was 111. Vidal was negative, scrub typhus positive. Coming to CBC, HB is 8.2 mg per dl, TLC was 14,700, RBC 2.7, platelet was 2.7 lakh, ESR 60 mm per hour. Sample was again repeat on 9th of March. HB was 8.6 mg per dl, TLC was 13,000, RBC was 3.1, platelet count was 2.6, ESR was 66. Coming to chest X-ray, shows right pleural effusion, CT brain shows multiple well-defined peripheral calcified rim seen involving brain parenchymal with obvious adjustment edema. Query granulomatosis lesion or metastatic. Coming to medication, injection Taxim 1 gram BD was given for 5 days, and after that injection meropenem was started 500 mg into BD, injection Aciloc 50 mg into BD, injection doxycycline 100 mg IV into BD, Injection Onden 4 mg IV into TDS before food. Injection Buscopan IV into BD. Injection Livipil 100 mg into BD. On admission, BP was 60/40, so injection Norate to ample with 500 ml of NS at a rate of 16 drop per minute was advised. After 4 days, BP was 100/70 without injection Norate. Injection Fabridol 100 ml IV into HSOD. Injection Diclofenac 1 ampoule into SS. Coming to oral medicine, Tabsiritinib 150 mg. There is a typing mistake. 1 tab into BDPC. Tab Feronia XT 1 tab into BDPC. Tab Azithromycin 500 mg 1 tab into ODPC. Tab Dolopar 650 mg 1 tab into BDPC. Tab Udilip 1 tab into BD. Coming to psychological aspect, need support to do daily routine, affect the emotional health of patients, families, and friends, anxiety, fear, stress due to life-changing experience, fear of pain and suffering, concern for family members and his wife, fear of dying, fear of rejection, financial problem. Main concern, generalized weakness, loss of appetite, loose stool, anemia, fever, pain, psychosocial stressor. Coming to summary, a 32 years male patient admitted in medicine ward on 5th of March with the chief complaint of fever, headache, vomiting, loss of appetite, 2 episodes of seizure. On admission, patient is conscious and oriented. He was diagnosed cancer of lung stage 4 on December 2019. Chemotherapy was not advised. Instead, the tabsiritinib 150 mg per oral BD was given. Scrub type was positive on 6th of March 2022 and started injection doxycycline. All routine investigation was done. Chest X-ray shows right pleural effusion. CT brain shows multiple well-defined peripheral calcified rim scene involving brain parenchyma with obvious adjustment edema with query granulomatosis lesion or metastatic, further suggested due to MRI brain. Counseling was given and patient was improved a lot. Coming to discussion point, what more can we do as a nurse for this patient to improve his quality of life? What other support can be given to this patient and families? Thank you.
Thank you, Divila. Stella ma'am, there is a question in the chat box. What is the meaning of abbreviation HSOD?
Where they found this one? I'll just find out. So meanwhile, someone can, what more can we do as nurses for this patient to improve his quality of life? Anyone? I want to ask a question to Nimila. Nimila. So when this patient had come to you with what to say, with seizures, what did you expect to be having the patient was having? Nimila?
Yes, ma'am.
When the patient, you said the patient was admitted in the hospital with the chief complaints of fever, headache, vomiting, loss of appetite, and 2 episodes of seizures. Okay.
Yes, sir.
Okay. Only after taking CT brain, you came to know the patient is having mets to the brain, right?
Yes, ma'am.
Okay. I just want to know when the patient had come first to you, okay, what
what did you feel the patient will be having? Otherwise, what went into your mind the patient may be having, what problems the patient may be having? Otherwise, what is the diagnosis, clinical diagnosis you could make when you have seen such patient?
Some neurological problem.
Pardon?
Some neurological problem.
Some neurological problem. Okay. First, we'll go to again to the last one. Last slide. Let it be. Okay. So what more can we do as nurses for this patient to improve quality of life? What other support can be given to this patient? First and foremost, I would like someone asked about the HSOD, health status outcome dimensions. It's a healthcare analysis, health status outcome dimensions. Okay. Now coming back to this one, see, any patients with cancer patients, especially advanced cancers, and with a patient with CA lung, when the patient must have come to you at that point only, but usually in a palliative care, when the patients are coming with severe headache, fever, in some patients there will be confusion. The patient may have having even delirium. The first thought, if I was the first thought could have come in my mind was brain meds. Okay, that is one thing. Second thing, this we have to explain to the family member. Okay, because patient, they will also be thinking why suddenly the patient is having seizures, why he is having fever and vomiting, and this fever and vomiting could have been started maybe 1 or 2 days before also. So whenever a patient is coming to you, in such cases, you can just ask the patient, if the patient is coming to your OP, patient is having fever, anytime any headache, that could be done. When was he diagnosed for CA lung? Saraswati is asking, 2019 if I'm not wrong. Okay. So it was brain meds. Okay. So usually in brain meds, if the patient is in an advanced stage, what we do usually in palliative care is we give dexamethasone, so that whatever that peri or this one tumor edema is there, it will reduce, and his seizures also can be reduced. Of course, he has to be put on medications and all that comes afterwards. Okay. So one way to improve the quality of his life is first and proper assessment. I will tell you. If you have done a proper assessment, you can report to your doctor that these are the problems with the patient and that you suspect patient is having brain mets. It is just you are thinking like that. Second thing, you have to take measures to prevent the patient's fall. Seizures, you all know what will happen in seizures. They may bite their tongue, everything happens, they will injure themselves. So that is the third. Fourth thing, we have to educate, empower the family members about this thing, because they are unknown, they don't know. Because here the prognosis is also going to be bad. So we have to communicate with the family that the patient is having so and so problem, and that is why he had the seizures. Okay. Now quality of life. Now quality of life, the patient is having pain, we have to reduce the pain. That's the first and foremost thing. Second thing, a person needs to be with the patient, because anytime he can throw his seizures. So correct time medications we have to give to this patient. Find out from the patient what's the patient's concerns. As you said, one of the patients, he was worried about his family because no children, only his wife was there, right? So that is another concern of the patient. And headache, he was complaining. So pain, so we have to reduce the pain. Yeah, very right. Kusum has said monitor vitals and fluid and electrolyte balance. Very right. So we have to what I said was, yeah, we have to reduce the patient's pain, prevent the patient's fall. We have to start medications for the seizures, and sit and talk with the patient, because he has a lot of distress. Psychological problems are there with the patient. because he's going to leave his wife alone and he is moving. So that already, and he's an police officer also. So he may be knowing that what is his condition, what is happening with him. So we need to sit and talk to him. What is his concern for his family? And if something can be done by us, we have to do it for that. Even we can explain or talk to his wife that his husband says that he wants so and so thing. That is very important. Okay. Then the second thing is what other support can be given to this patient. Now, if you people can do a home visit, that will be better. Every now and then, if coming to a hospital may not be feasible for these people, especially after some time the patient's condition may progress. So in that cases, starting first itself, starting a home care visit, that will be better. Focusing on total care of the patient, not only the physical, psychosocial, spiritual care also we have to focus. Another thing what I have to tell you is patient may go for delirium. So we have to empower the family member, otherwise educate the family person, caregivers. If the patient is having delirium, so you have to talk to them. See, delirium means these are the symptoms of delirium. At that time, what can be done? Because they will become panic. They don't know what is happening. So empowering the patient about the delirium also is very important. At least they will know, okay, this can happen, and that time what they have to do. Electrolyte imbalance has to be maintained, because that also can be one of the causes for delirium. So very small things can be done for this patient and for his family. Involving in decision making is another thing very important with the patient's family. We have to sit with the family, communicate with them what are the problems going to happen, anticipating the problems, and how we can handle it. Decision making, why I said was, if the patient becomes coma, or the patient already it is advanced, fourth stages, already it is advanced. In that cases, when the patient's condition is becoming more bad, whether they want to bring the patient to the hospital, put in ventilator, these things, so many things has to be taken decision. So we have to sit and talk, communicate with the family member, what they expect from us, what they want to do when this condition is going to worse. Whether we have to, whether DNR, do not resuscitate. So we have to explain these things, talk to them, so that they can take a decision, and accordingly we can intervene in these things. Here so many things have come. Monitor vital signs and fluid and electrolytes, assess the level of ADL, involve women in care, patient and family counseling. Nursing care and nursing interventions is very good. Empower family for total care of the patient. Okay. Concerns, why I said maybe the patient already knows he is dying. He had some concerns. He want to do something for his wife or for what other family members. So we can just ask him, and ask him also what is his decision about. So these things are very important. Psychosocial support, very right. Monitor oxygen saturation. Yeah, psychosocial support is very important. And psychosocial support should be ongoing process. So that is why I asked if you people can do a home visit and nothing else. Nimili, you are from which place? Hello.
Sikkim.
Yeah, Sikkim. In Sikkim, do you have palliative care, right?
No, ma'am, it's ongoing process.
It's an ongoing process. I think in the government, this one, they will have a palliative care, because already in Sikkim and all, people have come and taken a training and they have gone,
Yes,
in my
ma'am, but
knowledge.
that proper unit, it's constructing, under
Okay, okay.
construction.
Maybe due to this COVID and all, it was stopped, right?
Yes, ma'am.
Okay, so another thing what you can do is make a phone call for the patient if they don't find any problem, and if your team doesn't have a problem, because the patient once goes to the patient's village, it will be difficult. At times they want to find out some things and all. So you can have a this one WhatsApp call or a video call, just to strengthen them, just to empower them, educate them. If they are finding some problem, you can tell them that they can call you, so that you can support also. I'm not talking about medications. Okay. Other things in the nursing interventions, what we can do. So in that case, you can do these things also. So nowadays, after this COVID started in many places, even in Pallium India also, they are having psychosocial support team is there. If they are finding some psychological problems, they can talk, the people are there who can talk to them. Same thing you people also can do. Okay, just communicate with the patient and the family. They will have a lot of doubts. That doubts you can clarify, you can clear their doubts. And if you find it difficult to clear, you can ask one of your doctors or counselors who are there, just to sit and talk to them. And these are some things that you people can do for the patient and the family. Social support, they have to find from the local area itself, local community. If there is some social support, try to find out if there is any organization. Most of the places there will be some organizations, maybe even. So I will just tell, like, for an example, I will tell in Mizoram. Okay, I have been to Mizoram. I found in Mizoram they have a Christian community, and youth, youngsters are the youth are there. Okay, so that is the social support. They support the family when they are having problems and all. So like that, even if you have a community in a local communities, local organizations will be there who support the local people for some problems. So if you know someone like that, you can uh, get in touch with them and ask them to help these people. Maybe at least like a volunteer, sit and talk to the patient and the family, someone to listen to them what they. So these things can be done. Yeah, Ali Garbian has said giving analysis improves the quality of life. That's what I said. Pain relief, very very important. Yeah, Kalaivani, Jaya Sharma, all are asking. Yeah, Kalaivani first.
Actually, when I was working in a corporate setup in neuro ICU, one client had a disease called a Becher disease. It's a neurological disease. It's a autoimmune disorder. Actually, she was 33 years old, and they are telling that she cannot be able to recover from the disease. And she's having a complaint of abdominal distension and constipation for several months, it seems. And she cannot able to move her limbs, all four limbs. And finally, what a doctor told to give is injection buscopan and metoclopramide. And even that she cannot able to tolerate her pain, and her constipation was still there. And finally, he has to give us adenosine, injection adenosine, and we inserted a flatus tube for her, and after that we gave her adenosine injection. While we are measuring her abdominal girth, it was very high, like 113 centimeter. After giving adenosine, her distension become uh, decreased, and decreased it is about uh, uh, 90 plus in centimeter, and she relieved from the pain soon after giving that medication. Do you have any experience of giving adenosine injection for treating pain, ma'am?
No, dear, I don't have any experience in giving this one. And you told me you passed flatus also, flatus tube, right? So he has
Yes,
passed that. The patient has passed flatus.
yes, ma'am. We cannot visibly see, and we have tested a bowel and water test after inserting the flatus tube, and
Yeah,
we
yeah, yeah.
visibly
So
that
I
she has
know.
passed very.
No, maybe there was pain management. No, when you have given adenosine, there must have been some action must have taken place. But with that, putting a simple catheter, and when the flatus comes out, I have seen some patients who are having this problem. The flatus comes itself, they will be relieved. Usually, when there is abdominal distension, abdominal girth, and all, we put a flatus and see now when it's flatus tube and see whether the flatus is coming or not. Putting in water, maybe, but I don't have any experience in giving this injection here.
Thank you, ma'am.
Jaya?
Good afternoon, ma'am.
Yeah, good afternoon, Jaya. How are you?
Fine, ma'am.
Yeah.
Ma'am, actually, I have 2 points regarding this. Just want to clarify what were the number of days of hospitalization, and secondly, and the seizure status, like it was status epilepticus or the seizures were controlled. So I just want to ask to Nidima if she
Yeah, you
can.
can ask. Nimila?
Nimila, are you there?
Ma'am, yes, ma'am.
Yeah, this one, Jaya is asking you a question.
Yes, ma'am.
Nima, can you just throw a light on his status of seizures, whether that patient was having continuous seizures or what were the number of days of hospitalization? And then if the condition has improved, I just, because after that, I would like to share one of the incident which has happened recently in our hospital.
He was complained of 2 episodes of seizure only. After that, we did not find any episode.
Yes, thank you.
He was about 15 days, I think, for hospitalization. After that, he was discharged.
Okay, thank you so much, Nirima. Actually, I just want to know whether he was advised for whole brain RT, because normally with CA lung and brain mets, if the patient investigations are normal and patient general condition is fine, so we can always go for whole brain RT. Was it advised for him, or due to the condition it was it was not advised?
Not advised.
Okay, thank you. And normally, I want to share one incident where one of my patient, she was a case of CA breast. Now she is no more. She had status epilepticus. She had she was diagnosed with CA breast with brain mets. So earlier we were planning to we were giving her anti-epileptics. Still, she was having pain and fever, and these patients have a lot of pain. So we started her on morphine, and we were also giving her PCM and everything. We were giving, and ultimately what happened, what turned out to be the final outcome was like, we have shifted her to a room, a single room, so that we can give and visitors were also not restricted, so that the end moment she was not responding to the treatment. So we have shifted her, and we were giving only supportive management, because sometimes it happens we cannot do much. At least we can give the peaceful death, and then we can do the counseling of the patients, and we can also advise them, like, if you want to take the patient to home, or you want to want to stay in a hospital. So in government hospital we can do that, but in corporate it will be like patient's choice only, because they have to, the family has to bear the financial they have to see the financial aspects also. So I just wanted to share this incident, because nothing could be done much, and she was then finally, we have just protected her airway, and then we were giving anti-epilepticus, and then analgesics, and nothing more than the oxygen therapy. That's it. So this is about the quality of life.
Yeah, that's
Which
what
we
I
were talking
said.
about.
Jaya, very rightly
Thank you
said. That's
so
what I
much.
was telling, Jaya. When you know the patient is going towards this one, and especially if the financial problems are there, they are very poor, and especially in a corporate hospital, this can, and even in a government hospital also, how long you're going to keep? So communication is very important here. To take a decision without communicating, how they are going to take a decision? So we have to communicate with the patient and the family. At least with the family, we have to communicate. These are the problems. These are things what is going to happen. So they can take a decision. So if they have to take a decision, we have to sit and spend little time with them to explain the things. give them time also to take a decision. And as you said, yeah, patient can be supported in the local with the local organization and at home also. And as I said, over the phone we can talk to the patients. What the patient needs here also, the patient needs pain management, the patient needs nursing management, that you the nurses can teach them before they come how to make a bed, catheter care, if the RT is there, RT care, and these things, punch bath and all, we can teach the patient. Pain management, why pain management is very important, what time you have to give the medication, why the medication is given, especially morphine fourth hourly means why it is being given. See, just giving and telling them fourth hourly you take the medication is not enough. We have to tell why it is given fourth hourly. So each medication when we give, we have to tell them why is this is being given fourth hourly. That is very important. And quality of life, maybe he wishes to have die at home, he want to be at home, so that is very important. So we have to what to say, we have to acknowledge their emotions also, their concerns also. Okay, and for all the nurses I would like to tell, not in any type of cancers, okay, when the patient is in advanced stages, especially in some of the cancers where the patients will go for meds, no, as nurses, our assessment is very, very important. Like CA breast patients, CA lung patients, usually they will go for brain meds. So the starting itself, they will have, right from beginning, they'll start telling mild headache, fever. These are the slow symptoms starting. Okay, so we can take care of that. Now we can say spinal cord compression patient, the patient who is having a CA prostate, otherwise any other gynec what to say, malignancies. The most important thing is whenever you visit such patient, whenever you talk to the patient, just ask the patient, do you have any backache? Do you feel weakness of the limbs? When you walk, you feel that you are going to fall? And if the patient says, yes, I feel backache, and whenever I feel there is a weakness, it means there is a spinal cord compression, there may be a meds. Okay, immediately we can intervene in that. That's what I said, dexamethasone, steroids given in high doses can reduce the edema and the patient won't become a paraplegia. See, a lot of things are there like this, which we have to talk to, and especially like brain met patients, they'll be delirious. So the family needs to know what is delirium also. We can ask even the family, anytime he was speaking, he had some confusion, irrelevant talk and all, and it means his patient was in this. So these things has to be anticipated, and we have to talk to the family members so that when the patient is having such problem, they won't panic. They know how to handle it. Yeah, of course they have to come to the hospital, that inside, but that time how to handle it, that is very important, and that is what we have to educate the family members.
Ma'am, there are a few questions in the chat box. I will read it out. In pain management, can we give morphine since he is diagnosed with a CA lung and morphine may depress respiration? It's asked by Badashisha.
1 second. As far as my experience, till now we didn't find any this one, especially when the patient is in oral morphine. Nothing like this one, what to say, respiratory distress. Okay, patient can be given morphine for the pain management, and we don't start patients on morphine on a high dose and all. That is one thing. Okay, we do a trial and we find out how much has to be started, then only we start this one. But to my experience, this past 15 years, I have not find any respiratory distress. Patient was using more morphines. Okay, next question.
Is methyl prednisone an alternative dexamethasone for relief edema?
Yeah. In some cases, we give even methyl prednisone also we have given. Okay, but dexamethasone is available means that can go. And someone has that, who was that? NTS Ali Naji. If patient has lung cancer, can we focus about lung function test and working ABC and follow patient about hypoxia and hypoxemia and give him oxygen support? See, Patients, first and foremost, remember one thing. See, this all can be done. Okay, if the patient is not paying, that's what I will say. Okay, if the patient is having financial problems, by just seeing the saturation itself, you will come to know how much saturation, and then you can give a oxygen support. Otherwise, just pricking the patient is not good. Why to give all the problems to the patient? And before doing any procedures, please ask the patient whether patient and family whether they are willing to do it. Unnecessary, we will do all APG and finally they have to pay from their pocket. I was out due to bad internet connection. Thankfully, I got the connection. If patient is NPO, who given morphine? Yeah, the patient is on this one NPO. Morphine can be given by subcutaneous also. Divided doses are there. It is about morphine. Pain management is taken already. Pain management is taken already, dear.
Yes, ma'am. Yes, ma'am. Yes.
Yeah. So yeah, if you have a palliative this one physician over there, they will put the patient into subcutaneous morphine. Subcutaneous morphine also can be given to the patient. That will relieve his pain. Jijo has raised his hand.
Jijo, please unmute. You're muted, Jijo.
Yeah. Hello.
Can hear you, please.
Hello, madam. My name is Jijo.
Jijo.
So I am working Patna, one of the HIV palliative care. So my doubt is that we are getting right now severe PCP patient, pneumocystic pneumonia patient.
Due to COVID?
COVID also means advanced HIV also. COVID also is there, and also we are suspecting the means we can do the CT because of patient is severely respiratory distress. We can move the patient. So that kind of patient, sometimes we are using morphine, low dose of morphine due to anxious or that respiratory rate. It will help to calm down the patient also. So it's means no more pain and nothing. But this condition, we can go for a means a regular dose of morphine or not. It will effective or not. That is my question.
See, we say the dyspnea drive can be reduced with morphine.
Yeah.
Okay, we do it in palliative care also. But only thing is you should have someone to monitor it.
Yeah.
Okay, see, that's what I said. You should have a palliative care physician who can titrate it also. Okay, so if I tell you you can done tomorrow, you and me, we cannot start the patient on morphine. That you know very well. Okay. So see, dyspnea drive. If the patient is having severe dyspnea, patient morphine can reduce the drive also, but it needs to be under the monitor of a physician. Palliative physicians means they know how to start it. Okay, because we do it here in palliative care, but I cannot tell.
My means morphine normally doesn't cause any respiratory depression. That's why my question is raised.
Yeah. Normally it doesn't cause a respiratory, especially in the oral morphine. See, I told you more than 15 years I have been seeing this only, and that also not 10 mg and all. 100 mg, 200 mg patient has taken one dose.
Okay.
4th hourly. Okay, we have seen patients. The patient never had any problem. Okay, but being you said this patient is this one lung problems are there. We have to monitor the patient. That is something.
Really.
We cannot say like that. So we have to monitor a patient because and it can happen, especially when there is a history of bronchial asthma. Patient is having lot of problems. We have to monitor also. See, I myself before joining palliative care, I have seen I remember one of our anesthetists. The patients who are in ventilator, COPD patients, severe, put in ventilator, used to give morphine to reduce the secretions and the cough. I have seen him. And that time I used to think also, because I have witnessed one patient who had come with myocardial infarction, was not given a history of bronchial asthma and was given morphine, and hell of it what happened after that. Okay, bad thing happened. But here I have witnessed this also. But been working in a palliative care since long, patients are taking morphine without any problem. The only thing is you have a palliative, you may be having a palliative physician or doctors who have done something.
Yes. Yes.
We have never gone through any respiratory disorder.
Okay. Thank you, madam. Thank you.
Is dehydrated. What is the use of anti-dehydration for him? What is this? Surma Ahmad. If the patient is in NGT, is dehydrated, what is the use of anti-dehydration for him? Say, patient in NGT, maybe the patient is not given enough of fluid through NGT, and that's why patient has become dehydrated. In such cases, maybe you have to start a parenteral also for the patient to correct the dehydration. I hope Surum Ahmad. See, a patient who is kept in NGT, we say for NGT patients at least 2.5 to 3 liters. According to their condition, we have to give the fluids so that the patient won't be dehydrated. Okay. Now, if the patient is already dehydrated, been in NGT still dehydrated, it means the patient is not given proper fluid intake. Okay, and if the patient is severely dehydrated, having an electrolyte imbalance, like if the patient is hyponatremia, hypoglycemia, patient will have delirium. In these cases, immediately we have to put a patient on a parenteral fluids so that we can correct this. Okay. Okay, dear. So
thank you, ma'am. Thank you so much.
And thank you all so much, and all the best for your further sessions and for your exams. Okay, bye. Bye, Jaya. And bye. Where is Vani has gone already. Okay. Bye, Kusum.
Thank you, ma'am. Thank you so much. Bye.
Okay.
And all of you, I think I have shared the feedback link in your group and in the chat also. So please go through it, and I have corrected almost all of your assignments. Assignment 1, almost all of you have passed the assignment. I'm so happy about that. And it will be shared through your mail next day. Next day it will be shared. And thank you all. We'll meet you on the next class. Until then, bye.